start with this session, Setting the Scene, Type 1 Diabetes. In the preparation of this meeting, we spent a lot of time, of course, looking at the structure and the composition we had in mind. We also had preparatory working groups engaging some of you who are here, and thank you very much for your time and commitment to that. It was clear from all the three working groups, which in fact will also be seen later on in the day when we have the breakout sessions around access to medicines, around governance, and around health system reform. It was clear from all the three groups that what would be very important today and in this conference would be the country perspective. And most of all, the view of the health authorities in the countries that we are discussing in this meeting. And that's why the coming 2 hours and a bit will have a very strong focus on the country perspectives. But the other thing, as you have been able to see in the material that we have been circulating, which has set the frame for our conference, is the Global Diabetes Compact, which was, as Bente has just explained, launched in 2021, followed by the Global Treatment Targets, Coverage Targets in 2022. And for us to get the frame set for our conference today and tomorrow, we have invited the WHO Global Diabetes Compact representative to give us an introduction or an overview of the Global Diabetes Compact. And I could not think of a better person to do that than Sanjana Mapadkar from the WHO Geneva Global Diabetes Compact Group. So, Sanjana, please.
All right, thank you so much, Bent. And it's a pleasure to be here today and to share more about the WHO Global Diabetes Compact that was, of course, started under Dr. Mikkelson's leadership and that we have the privilege of continuing to carry forward. So I think all of us in this room today are aware that the global burden of diabetes is rising. WHO estimates from 2017 showed that 9 million people were living with type 1 diabetes, or 2% of all cases at the time. And this represents a small but vitally important proportion, impacting millions of people who rely on continuous access to insulin, care, and support to survive. These estimates also demonstrate that about 60% of people living with type 1 diabetes are over the age of 40, and a little over half live in high-income countries, really stressing and reinforcing the urgency of ensuring equitable access to insulin and care. So it's against this backdrop, as we've heard, in 2021, that WHO member states or countries adopted a milestone resolution calling for strengthened diabetes prevention and management. The resolution had a set of asks, not only for member states, but also for WHO, including, for example, the development of global targets and pathways to achieve them, support for strengthening monitoring and surveillance, improved access to essential diabetes medicines and related health technologies, and adequate and sustained financing. So in response to that resolution in 2022, member states adopted these 5 global diabetes coverage targets to be achieved by 2030. And Dr. Mikkelson, of course, walked us through them, and I will just reiterate them because they're important. 80% of people with diabetes are diagnosed. 80% of people with diagnosed diabetes have good control of glycemia. 80% of people with diagnosed diabetes have good control of blood pressure. 60% of people with diabetes 40 years or older are receiving statins. And of course, 100% of people with type 1 diabetes have access to affordable insulin and blood glucose self-monitoring. The resolution was, of course, complemented by WHO's launch of the Global Diabetes Compact in April 2021, which intentionally coincided with the 100th anniversary of the discovery of insulin. And as Dr. Mikkelson noted, there was a strong showing of support from high-level heads of state, ministers of health, and many people in this room and stakeholders in this room coming together under the larger vision of the compact. And to achieve this vision and achieve the global coverage targets, the Global Diabetes Compact works across 6 priority work streams. The first on access to essential diabetes medicines and associated health technologies. The second on development of technical products. The third on prevention, health promotion, and health literacy. Fourth on country support. Fifth on research and innovation, and sixth on governance. And very importantly, none of these work streams are meant to be standalone efforts, but are interrelated in order to push us towards meaningful progress. So with that in mind, I wanted to share some key highlights across each of the work streams. And starting with work stream 1, one of the key initiatives is WHO's ongoing dialogue series with the private sector. These discussions aim to encourage progress on a set of WHO asks to improve access to essential diabetes medicines and related health technologies. An important success from these efforts has been the pre-qualification of human insulin and glargine. Work is also ongoing to pre-qualify blood glucose meters and point-of-care HbA1c devices. In 2023, WHO updated the essential diagnostics list to include guidance on personal use of glucose monitoring devices, an important milestone. And work is ongoing on an NCD medicines forecasting and quantification tool to help countries anticipate demand, and that is expected to be piloted later this year. And finally, WHO continues to ensure that diabetes medicines included in the essential medicines list are appropriate for children. Workstream 2 supports our standard setting and normative work. Our current guidance and technical packages have type 1 diabetes integrated into these packages. And so, for example, our HEARTS-D, given that the focus is at the primary healthcare level, there are recommendations to refer a new clinical suspicion of type 1 diabetes to a higher level of care. We also have guidance on pharmacological agents for managing hyperglycemia in type 1 diabetes and type 2 diabetes in low resource settings. And to support countries track progress towards the global coverage targets, WHO has developed a global monitoring framework for diabetes. And type 1 diabetes is also supported through some of WHO's broader NCD-related resources. For example, the NCD Best Buys, which outline cost-effective interventions to manage diabetes and reduce complications, as well as the NCD Emergencies Kit, which helps bridge treatment gaps in crisis situations by providing essential supplies, including human insulin and blood glucose monitoring devices. And while type 1 diabetes is integrated into these broader resources, looking at our products in the pipeline, we're actively developing new resources to address some specific needs. And a key focus of this work is applying a life course approach because, as we know, this is a lifelong disease. And so if you look at the first column, for example, we have guidelines on the management of hyperglycemia in pregnancy, on managing type 1 diabetes in children, and on insulin treatment for adults living with type 1 diabetes. And in addition to clinical guidance, we're also developing resources to strengthen monitoring and surveillance, particularly at the higher levels of care, to improve tracking. And given the increased burden, of course, of related conditions and comorbidities, we're also expanding work there, for example, around the relationship of oral health and diabetes, as well as chronic kidney disease. And so overall, all of these efforts reflect WHO's commitment to both a comprehensive and integrated approach to type 1 diabetes care. Under Workstream 3, Health Promotion and Literacy, we have ongoing work on therapeutic patient education, which is a structured, person-centered education that's delivered by healthcare providers to support self-management of chronic conditions. And the curriculum that is focused on diabetes is being led and developed by our regional colleagues in the Eastern Mediterranean region, and it's anticipated to be piloted later this year. WHO also has available guidance on physical activity to support healthy lifestyle habits and improve diabetes management. Our fourth work stream is, of course, incredibly key because we need to be able to translate all of this work at country level in order to have impact. And one way we do that is to support regions regionalize the Global Diabetes Compact. So since its launch, several regions have started to adapt implementation frameworks to their unique epidemiology and needs. And these are key opportunities to strengthen, of course, type 1 diabetes care and prevention, care and treatment, as well as strengthen national prioritization and push us towards achieving these key targets. One key initiative of WHO that I wanted to share is DCARD Africa, or the Diabetes and Cardiovascular Diseases Initiative in Africa, that was developed in collaboration with colleagues from Ghana and Uganda who are here with us today. And the overall goal is to really build up the health system's building blocks in order to improve access to diabetes care and treatment, primarily at primary healthcare level. There's also, of course, the WHO Afro PEN Plus regional strategy that was adopted by countries in the Afro region in 2022. And this aims to strengthen the continuum of care, particularly of conditions that are treated at first-level referral facilities. And type 1 diabetes is one of those focus conditions. And I know there are many partners in the room today that are supporting the implementation of this strategy. Under Workstream 5, WHO, in collaboration with the University of Geneva, launched a new global diabetes research agenda, which presents a list of 65 research priorities for diabetes in low and middle income settings, as well as key considerations for the translation of research into policy and practice. And also, given the use of AI for retinopathy, WHO is developing standards for AI-based technology to ensure their safety, effectiveness, and equitable implementation. And finally, we have a broad stakeholder engagement framework because WHO cannot do this alone. And this includes engagement with regions and member states, as I mentioned, engagement with non-state actors or non-government actors through a platform called the Global Diabetes Compact Forum, which currently has over 140 member organizations. Very importantly, engagement with people living with diabetes, and of course, engagement with the private sector. So moving forward, and as we're looking towards 2030, we hope to continue supporting some of these priorities that are listed on the screen, including integrating diabetes care into primary health care and moving us towards universal health coverage, promoting self-management, strengthening monitoring systems for diabetes, advancing research, and of course, bringing together and uniting multi-sector stakeholders at various levels as we move towards achieving the objectives of the Compact and the global coverage targets. I just wanted to end by saying if you want to continue to stay engaged, there's a QR code on the screen. You can sign up for a monthly newsletter, or if you know of an organization that might be interested in the Global Diabetes Compact Forum, the link to apply is there as well. Thank you.
Thank you very much, Sanjana, and I believe it was very important for us to get this overview of the Compact. It's, I would say, very comprehensive aspirations, as we've seen all along, but also the progress. Now, you didn't have time to go into all the details, of course, but it is operating at many levels. I would say one particular moment was the endorsement of the implementation framework at the WHO Regional Office for Africa regional meeting in August, but we've seen similar mechanisms of progress in all the WHO regions. We will allow a few questions to you, if you don't mind, and if you don't mind taking the seat. If there's any questions to Sanjana WHO about the Compact, you're also welcome to keep the questions, because we will then move to the next part of this session, which is about research. And you said in one of the components of the Compact about around research as a key component. And as you've seen yesterday, we had a very important track here of the week, the Early Career Researcher track. And we had invited, I believe, around 30 young researchers from different parts of the world. And not only as a separate track, but as an integrated part of our conference. And the intention is also that the researchers and the area around research continues to play a part today and tomorrow. And for making that bridge, we now have a panel that we have entitled Global Research Community Representatives. So I would like to invite Jean-Claude Cattet to the stage, and also Maria Lasso and Sarah Wild. Jean-Claude Cattet is from Cameroon and a research fellow in global health and diabetes. Maria Lasso is from the Center of Excellence in Chronic Diseases in Lima in Peru. And Sarah Wild is with the University of Edinburgh. And I would like to start out this panel with a question to you, Sarah. Now we have the Global Diabetes Compact, and we have a long history of research in the area of type 1 diabetes and diabetes more broadly. And given where we are right now, with the challenges that we see with the burden from diabetes, and in this context, type 1 diabetes, I'll ask you, I would say, a big question, but I know you're capable of responding in a concise way. But if we look at it from a macro view, comparing today with maybe 10, 15 years back, and you've been part of this community for that period of time, where do we stand today compared with maybe 10 years ago, with results of the research, the quality of the research, and maybe even also how we are looking at scientific methodologies and data? Please.
Thank you. That is a big question.
Yes.
I'm definitely an optimist. I think things are getting better. We certainly know more than we did 10 or 15 years ago, but I'm hoping that in the future, in the next 10 or 15 years, there'll be an increase in knowledge. As you've inferred with the Global Diabetes Compact, we really need to know how many people there are with type 1 diabetes, because how will we know whether 100% of them have access to insulin if we don't know how many people there are? And with colleagues in the audience, we've done our best to estimate the numbers of people with type 1 diabetes, but there's a lot of work needed doing in the next few years to improve those estimates that then will feed into assessing and evaluating progress towards the compact. So there are probably other aspects to your question, but I'll pause there.
I'd like to follow up with that part, because if you say that there's more to be done, how can we build a stronger global community around this? I mean, that's also the ambition of the meeting we had here and yesterday.
Well, I think a meeting like this is a really good start. We get to meet people who we've not met before, and to meet old friends, and then to build on opportunities for sharing expertise and local knowledge. Clearly, people based in individual countries know how feasible it is to conduct research in their countries, and what research is feasible. So that developing partnerships and collaborating and seeking support for research is the way forward, I think. I'm sure other people will look to the rest of the panel to contribute when they get a chance to answer that question.
I'll give you a last question, though, before we move on, because we had a chat before also, and you said there would be you suggested three key issues to focus on as a global research community to improve type 1 diabetes care in low and middle income settings. Please, if you could elaborate a little bit how you would see the agenda moving forward, or how you would focus a research agenda on type 1 diabetes with that perspective.
Thank you. Yes, I mean, I'm coming from a perspective as an epidemiologist and a public health physician, so I suspect people coming from other perspectives will have different viewpoints. But one of the approaches we use in public health when we're trying to set up services is a healthcare needs assessment that has different components to it. And the first component is epidemiology, understanding how many people there are with a condition. Then the next stage is something called comparative needs assessment, where you can look at similar countries and see how they're providing care, learn from your neighbours potentially. And then a key bit of a needs assessment is consulting stakeholders. So that's people with diabetes, but also local people providing care on the ground. And so that's the first stage. Then, of course, what you need to be able to do is to identify cost-effective interventions in each setting, and what's cost-effective in one setting will not be feasible in another. In some places, what you might need to do is to say, we've got this amount of budget, how can we spend it most effectively? And then the final point that fits well into this research session is that you need continuous evaluation and monitoring and adaptation as things change. When you start off a service, it will have rough edges and things need to change and be modified. And the people using the service, the care providers, will all have views about that. And then things change with new technology, changes in availability of different sorts of insulin and so forth, and services have to adapt to that. So those are the three things that I think are core components.
And reading some of the scientific publications you've been part of course, you've done a lot of research in the United Kingdom and Scotland. And maybe in the past there's been a tendency that we are in different parts of the world, but somehow the world is getting more connected in many ways, also as we see here in Copenhagen these days. So if you should take the best of the learnings you have from all this epidemiological study you've done in the United Kingdom and Scotland, what would be your suggestion or your view on a global sharing of practice?
I think there's a huge amount to be gained from comparing with similar countries. Certainly in terms of Scotland, in terms of quality of care for people with type 1 diabetes, we don't compare favourably with Denmark or Norway or Sweden. And we find it helpful to point this out to our politicians who can then support changes to make care for people in Scotland better. I guess different politicians are different, but I think there is it really helps to be able to see that countries in a similar position are doing things differently. And we need to learn from our friends and neighbours.
And even friends and neighbours who are maybe far away. And
absolutely.
Maybe the lessons you've learned from your research and the way it has been influencing policies where you are, while context can be different, the methodology and approach can be helpful. And that takes me to, and thank you very much, Sarah, and Sanjay and I'll just to warn you, I'll ask you to reflect on the panel interventions when we get a bit later. But Maria, welcome and thank you. You are from Peru and you were a researcher there, a young researcher there. Then you went to Switzerland, to Geneva, and worked with David and his group. And I believe you did your PhD and so on. And then you went back to Peru. And I was, of course, reading many of your scientific material that you published. And it's interesting how you have, well, from what I can see, combined your focus on, you can say, very context-specific perspectives in Peru with a global scientific methodology around models of care. And of course, the diabetes type 1, I could see some of the material. Could you reflect a little bit on how you have started as a career researcher in Peru, gone to the global level and gone back? Please.
Well, thank you for the invitation. Yeah, I think that when I started in research, I was focused on epidemiology, and I work a lot with numbers, I will say. And then, well, I was doing research in Peru, knowing more and more about the problems that we face and the different challenges. But then, for me, it was important to know what was happening outside the country and try to learn more and try to know more about other methodologies that can be applied. So my PhD was focused on implementation science, in co-creation, in process evaluation, and it's very aligned with what Sarah mentioned about these healthcare needs. So I started looking numbers, but also I realized that it was important to know more which stakeholders were involved, what they think, what were their needs. And then I was always very close to the intervention to try to find solutions. So I realized that using some methodologies, for example, as co-creation, when you involve a lot of these stakeholders to take decisions about the design of the intervention, was something that it was missing in my previous research. And also, once we implement these interventions, to know more what happened in the middle, no? Because sometimes we look like the final outcome, that is usually numbers, but we need to understand what happened in the middle. So I think that process that I have and what I learned, it was important for me to come back and to do that in my new projects that I am working now in Peru. And specifically in type 1 diabetes, it was, I think, very nice because I had been working in type 2 diabetes, and since, I don't know, 5 or a little bit more years ago, we started looking at type 1 diabetes. So for me, at the beginning, it was like public health, it's important, and we need to see the problems of most of the population. But then when I realized the life experience of people with type 1 diabetes, that they are not a big number, I will say, I changed I switched the way of thinking to see that even when they were not a lot of people, they were also important to look at and to try to find solutions to this specific group and their families. Thank you.
Thank you very much, Maria. And I think you elaborated very well, of course, in a short time, your progress as a researcher. And you were also part of the early career researcher track yesterday, together with Jean-Claude and 25 other researchers. And what was your impression of that network, or how do you see the future of a global network like that? Please.
Yeah, I think that sometimes what we miss a lot in research is like opportunities to connect with other people that are doing the same, or people that have the same goals or objectives. So I think that these type of opportunities are really important for young people, and also to have the opportunity to come here and to see a lot of people that you read a lot about, and know them in person, know their stories, know more closely their work. It's very enriching for us as young researchers. And I think that we never know what is the real impact of this type of interactions very early, but then we don't know in 5 years or 10 years what impact this will have, because later when we progress in our careers, maybe we will decide to work with someone that we met some time ago in this meeting. So I think that there is like a lot of opportunities with this type of meetings and networks, and I think that they will grow a lot in the future.
Thank you. And I know from David Barron and Thor Christiansen with the Danish Diabetes and Endocrine Academy that they had a very big aspiration with the group. This is not just a one-time event, and I'm sure you will elaborate later in the day, both of you. Thank you very much, Maria. I'll get back to you around the more context-specific work you're doing in Peru. But Jean-Claude, as an early career researcher, at least that's what we call you when you came here, and I think you have accepted that title. Starting your research career in Cameroon, and now also being exposed to an international research network. And I was reading some of your most recent scientific papers, especially you had done a study around mortality of type 1 diabetes, people living with type 1 diabetes in Cameroon. So if you see that recent publications you've been part of, and the background you come with from Cameroon, and then you come here, where would you see yourself in a global research community with a focus on, you can say, type 1 diabetes, or you can say low and middle income setting research networks, please?
Thank you so much, Ben. I think that's a very tricky question. Where would you see yourself? Because if I say I would see myself, in the sky, it might be very pompous, but, I believe that is where every early career researcher, wants to be. There are a lot of senior researchers in this hall that we look forward to and we want to emulate. We want to, be our versions of themselves. But the journey into diabetes and type 1 diabetes research specifically for me started when I was in medical school, when I was just finishing medical school, and I had the opportunity to be involved directly with the Changing Diabetes in Children program training for medical doctors who were interested in type 1 diabetes. And so that really kicked up with, the passion for diabetes care, but also for type 1 diabetes. And so during that period of time with training in Cameroon and then later a PhD in the UK, I've worked with global diabetes leaders on some of these projects, and which obviously led to the project which you mentioned, looking at mortality of type 1 diabetes in Cameroon. And we know that type 1 diabetes, historically, mortality has been high in Africa, and we know the reasons: poor insulin access, mistreatment with insulin. But what we were trying to look at is in that particular project was, even with insulin access coming through this different insulin scheme, if you look at mortality, certainly it has reduced, but we don't have hard data from what happened 30 years ago. And if you look at current mortality figures, for example, in Cameroon, we saw it was around 33 per 1,000 person years. If you look at other studies in the region, whether Rwanda or Burkina Faso, for example, it's around 20 to 40 per 1,000. So really still comparatively high with regards to what you would see in Europe, which probably is around 0.8 or 1 per 1,000 for mortality. And so really to say that insulin provision programs are fine, but we should really put this within the context of these countries, because other factors may be contributing. So where do I see myself in the next 5 to 10 years? As a global leader working in type 1 diabetes, because type 1 diabetes is under research in Africa, in low and middle income countries, and underfunded. And we hope that meetings like this will be a place to discuss this and see how to reorient with efforts from WHO to encourage early career researchers to go into diabetes research.
Thank you very much. And you said it was a tricky question, but I think you managed to actually respond the way I had hoped, with the vision of, well, with the statement that we need more research, especially in some of the regions that we are focusing on, in this conference. Sanjana, you put here in your slide, advanced research on barriers to care and drive the development of sustainable solutions for type 1 diabetes management. And we are here together these days, and you know we have a group of early career researchers from the whole world, representing all parts of the world. And you heard from Jean-Claude and from Maria, and you've met some of the others who are here still with us today. The Global Diabetes Compact is a very ambitious framework, but if we look particularly on the research side, what would be the call from WHO, from the Global Diabetes Compact, to the research communities and the research community that we are trying to establish here?
Well, I think maybe I'll start by reflecting on the global research agenda that was published recently in collaboration with David and the University of Geneva, where pretty well thought out methodology was put into place to identify some of these key research priorities and with the focus in low resource settings. And the top three questions that came out were, well, around research around hyperglycemia and pregnancy, barriers to access of insulin and delivery devices, and then implementation research. And I think, with Maria, I heard you reflecting on the implementation research aspect of it, which we know is incredibly key, and particularly as we're thinking about how we move forward some of these regional adaptations of the Global Diabetes Compact. The implementation research it needs to be a very strong component of it, and it's a strong component of, for example, the DCARD Africa project that we are moving forward. So I think that is a one key area that we need to continue to develop capacity and to move forward with. And then, of course, reflecting on what Jean-Claude had mentioned, I think all three actually have talked about the need to contextualize, and we really can't make impact and move forward with the Global Diabetes Compact if we aren't thinking about how we contextualize at country level. And so maybe I'll pause there.
Thank you very much. And I believe of the many important roles and responsibilities of WHO, one of them is definitely to accumulate the research that is being developed by researchers as those we have in the panel, and take them to a global stage, cultivate, you can say, and bring the knowledge to the next level. And the question then to you, Maria, in that context, is in Peru, for instance, is the research community that you are part of, is it sufficiently linked to national policy processes around diabetes, to national research committees around policy making? How is that scenario evolving in Peru? As an example, please.
I think that it depends a lot of who is in the position of the policymaker. Chronic, as a research team that I'm part of, we have like 15 years working in research in Peru. Even when we are stable, our government is not so stable. So there are so many changes at the policy level that once we start an interaction with someone that is, for example, in the non-communicable disease program, after some months, this person change. So like keep the track of the support or the companionship that we can provide to people in this position, it's difficult to us, and also because I think as researchers we are working on our projects, and we need like additional time to invest in this interaction that is different, and also that we don't know a lot about it. So I will say that at this moment we are in a good position because there are someone at the in the position of the non-communicable disease program that is he really wants to work with researchers. He wants to involve us, and he's like keen to receive the evidence that we a bill to change some policies or to do, take some actions. We are, for example, planning to have a roundtable about access to insulin or access to medicine in NCDs. So I think that it varies a lot. We also are learning how to approach to policymakers, how to provide the evidence in an easy way, because for us, it's like we are used to these academic meetings when we present in 20 minutes or 30 minutes our research, whereas policymakers don't have time for that. So we also have to learn how to approach them and how to provide them the evidence that they need in the proper time.
So it's a dual mechanism. The researcher needs to be active and disseminating proactively the findings, and the health system needs to have a opening, a mechanism to absorb the findings that are there. In your experience from your work so far, Jean-Claude, how can we strengthen such mechanisms with the lens of type 1 diabetes care in low and middle income settings?
Yeah, I think before I answer that question specifically, I think there's something that we need to consider at a global scale with regards to implementation. And it's the fact that about 95% of what we know concerning type 1 diabetes, for example, comes from high-income countries, from white Caucasian populations. And I believe we are going to make the same mistake we are making in type 2 diabetes, where we consider these disease entities as a singular phenotype, and we transport whatever methodologies we've developed in European countries to sub-Saharan Africa or Asia. And it's true, WHO and other international bodies now are recognizing the heterogeneity that exists, between these two big diabetes entities. And so I believe for us, understanding, first of all, the biology of the disease will be important. Understanding the mechanisms, the underlying mechanisms driving the way type 1 diabetes present will be important. And developing new and innovative, bold methodological approaches adapted to our context will be the best way forward to address issues around mortality, complications, health system changes that we need to make. So, well, I don't know if I'm answering correctly, but this is what I believe would be useful going forward. And just really looking at what has been done in Cameroon as well, I think Cameroon stands in a very unique position that we've got global champions for diabetes. Some of them are present in this meeting. And there's a lot of crosstalk and fertilization between the research community in Cameroon and the Ministry of Health and other stakeholders, and really puts Cameroon in a favorable position. But I believe from the government's perspective and policy, a lot has to be done in honoring some of the engagement, but also from the researchers, probably a lot of advocacy, and speaking to the politicians always will be important.
Thank you. And just to say, there's no correct or wrong answer. We have a free dialogue today and yesterday and tomorrow, but your answer was very important, I would say, because you said leaders, and we have very strong advocates. Some of them are here, people with lived experience. We will also meet them during the day. Maybe we should also have more research leaders in type 1 diabetes. And maybe the network we are trying to ignite here could be one platform for having global leaders, research leaders in type 1 diabetes. We have a few minutes left, and I would like to also invite the floor to raise hands if you have any questions to the panel. Yes, could we have the microphone there? We have a few minutes before we will move to the next panel.
Thanks. Good morning.
Please introduce yourself.
I'm Mark Barone from the Intersectoral Forum of NCCs in Brazil. I have one question that is actually a concern. So we have seen shortage of insulin many times globally in the last years. So this question would be, do we have enough insulin if we want to achieve the target 5, so to provide 100%, so what is needed by people with type 1 diabetes? And my second question is to Maria. So I know that she has been studying point of care for HbA1c, and my question is if it would be a way to revert the serious problem that we have with misdiagnosis and also missed opportunity in therapeutical adjustment, which, you know, if it is, it would be amazing.
I think the first question on the insulin access, we have various panels today which will focus on that. So if you don't mind, Mark, we'll take that a bit later. This is for the research focus, the global research community. But I would like to take one piece up you mentioned about how to measure the global coverage targets. And I'm sure, Sanjana, it's a massive target. How will we measure it at the global accumulative way, cohort way? What is the approach right now in the compact?
It's a big question, and I'm pausing just because I'm trying to think about how to best approach this. So we just had a global monitoring framework released for diabetes, and there are indicators to support countries in tracking that progress against each of the targets, including that last target. Of course, I've had a couple of different discussions over the last day around that target. How do we achieve the 100% goal? And it's a very challenging one, but it's also one that is of ethical importance because insulin is such a life-saving treatment. And so I think as we move forward, as we implement the global diabetes monitoring framework and learn from that and learn how we collect that data in a way that is going to be meaningful, we'll be able to figure out how we strengthen some of that monitoring.
Thank you very much, Sanjana. I know it was not an easy question, and I'm sure we'll discuss it during today and tomorrow. If there are not any further questions, yes, please.
Hi, my name is Amos. I'm from Malawi. I'm a pediatric endocrinologist. Jean, I just want, I don't know whether it's a comment or anything, but it's something that probably some scientists in the room maybe can consider brainstorming upon. You talked about maybe diving into the biology of disease, type 1 diabetes. Probably, maybe from there we can find some groundbreaking, novel information that probably can help us advance in terms of taking care of our patients with diabetes. Don't you think, because I come from Malawi and I do manage these patients and I've observed a number of issues. Don't you think looking at interplay between environmental factors and maybe the behavior of biomarkers of the disease itself, of beta cells would be helpful, and also, yeah, the biology, the natural history of disease. We've seen quite a lot that has been done. We're talking of not reinventing the wheel. I thought if you go back to the developing countries, you'll notice a number of issues. For example, 90% of my patients come from the rural background. And those who are wealthier and richer are not suffering from diabetes. That's what I'm observing. Why? Why in Malawi? These are the questions that I'm asking myself. Is there something specific that the rural masses are exposed to, or the poor people are exposed to, that could be, I mean, one of the environmental factors that could probably lead to progression of disease. I'm seeing families having their relatives, brother, sister, quite a number of families now having diabetes. Could we study these families? I'm not into research yet. I do contribute to research in my country, but I thought maybe I could brainstorm with you on some of the areas which could be very instrumental when we're trying to develop an agenda to come up with novel practices in research. Thank you.
Thank you very much, Dr. Amos. And maybe just a quick reflection, final reflection on the comment from Dr. Amos, Jean-Claude, since it was directed to you. And then we will close the panel, please.
Yeah, I mean, your question has gotten the electrons in my body excited, because those are really quite interesting questions. And some of the work that I'm currently doing is really trying to explore that. And I've had the opportunity to work with other colleagues here in the room from Cameroon, Uganda, Tanzania, and South Africa, exploring these questions. And we would probably talk more after this. We have a couple of high-profile, high-impact papers coming up within the next few weeks and months, reflecting on some of these questions. So really, really important questions. And while we are trying to address these issues around the interplay between environment, biology, what I'm saying is that we should not also forget the other aspects around implementation. These have to go hand in hand. But once we get a good grip of understanding on how type 1 diabetes is in Africa, then we would better implement some of the strategies that we are talking about in this meeting. Thank you.
Thank you very much, Jean-Claude. And I think it was also a very nice conclusion of the panel you said about implementation, because if there's one thing type 1 diabetes care will need with the compact and in every country is a much, much accelerated implementation framework. And we have implementation research modalities and so on, which could be applicable. And we could have continued that dialogue. We will do that hopefully later in the day or tomorrow. But I would like to close this panel and give a round of applause to Sanjana, Sarah, and Maria.